Gippsland Primary Health Network. So predominantly I am in the Bass Coast, South Gippsland, but I do get around a little bit, so I do know a fair few of you. Just tips, please keep your microphone on mute. Ask questions through the chat section of Zoom. This section will be recorded. Please, we're happy for you to keep your videos on so that if you prefer not to, you can turn them off. Now, just in saying that, can you please ensure that your name on your Zoom is the correct name? Instructions to change it is you right-click on your image, on your beautiful picture, and select rename. If you're having somebody, if you've got two people in there, can you please put the second person into the chat so that we can make sure that we get a certificate of attendance out to them as well. The webinar recording and presentations will be available post-event. Evaluation survey will be emailed post-event. Please try and complete and submit that within 24 hours while it's fresh on your mind, and a statement of attendance will be sent out on receipt of the evaluation survey. This is just giving you an overview of population health statistics for COVID testing in Gippsland general practices and in the respiratory clinics. So that gives you an idea of, we've had the highest weekly totals to date, and through the COVID clinics as well. Okay, this is from the Polar reports. It shows patients with COVID-related contact in Gippsland by the week. So that sort of gives you an overview of the last, well, nearly 12 months, I suppose. Our presenters, Marg Jennings, most of us do know Marg well. She's a microbiologist, infection prevention and control consultant. Oh, I did that well. Margin Education Service is a provider of infection prevention and control education. She's a former microbiologist and has worked in clinical and research, bacterial, viral, immunology laboratories, and has been a lecturer and tutor at tertiary levels. Thank you. There'll be opportunities for questions throughout the presentation and a question and answer discussion before we finish. So with that, I will put you over to Marg.
Thank you, Tanya, and welcome everybody. You're probably all wolfing down a can of tuna or some cold baked beans or something like that. I'm just waiting for that to switch over to my face, Tanya. I'm looking at you.
Are you?
Yeah, which is lovely. But when I show people stuff, they probably want to see me doing it. So do I? Here we go. You've spotlighted me. That's great. Again, thank you, everybody. Now, different flavour today. A few months, long time has elapsed since we've last spoken. But I want to think about you in the Gippsland area, broad area that it is. And this is how I'm thinking. I'm thinking tourists coming down from, you know, New South Wales. That's about as far as they're going to get, I think. So I want you to think about people who are coming from a state where they're not used to wearing masks. They're possibly going to walk into your clinics, have no idea that we're expecting people to wear masks in our clinics. So please have a supply of masks. Also, they won't be used to booking properly by phone rather than online. Hopefully you haven't ditched all that, because what I want to say is COVID normal is COVID, is COVID-19. So that's one thing, the tourists and constant reminders. I'll also talk about why we are in that space. When you say, hasn't it gone? My answer, of course, is no. The second group I want you to think about are the 35,000 citizens who are wanting to come back into Australia, preferably before Christmas. And some of those a number of those will live in the Gippsland area. So, and a number are positive. I think you can have a look at the figures every day. Coming into Australia, the tests done every day throughout all of the states and territories are showing, I think we've got 8 so far today. So it's between about 8 and 18 every day, new positives coming into Australia. Now, you don't have to be Einstein to work out that unless your infection prevention control is absolutely expert and fabulous in quarantine, that there will be breaches and potentially leaks. And if you're not really sure about whether that occurs, let me just refer you to what we know has happened in South Australia and Adelaide. In the last 2 months, there's been 100 breaches. Now, don't sort of, fall on the floor and say how bad they are. This can be as simple as somebody throwing somebody a cigarette lighter. This can be as simple as somebody not doing hand hygiene after glove removal, but 100. I think they're actually a little bit more serious than that, and I'm sure you've heard about people. I think we didn't get the right stories for 2 people, and a couple of people have been vilified. It's always worthwhile getting the story right. So the poor first person who spread it was feeling, I can't tell them that I'm getting cash in hand. Whereas, the position we've taken in Victoria is to encourage the truth and that we're not the tax department, but we want to know really who you've had contact with. The second case, which was the other day, the person, the story was the person was positive and yet went out. And that's actually not the story. So just be really careful about tut-tutting everybody. I think it's a little bit like what happened in the quarantine issue here. If you look at it broad picture, no states were giving anybody an hour out for, a break during the day. Then I'm sure you're aware there was a suicide in quarantine in Melbourne. And as normal thinking human beings, the department thought, gosh, we can't have this happen again. What will we do? And so the plan then was to take people outside for an hour each day, which sounds reasonable. The step that was missed, of course, is that the security guards went from people who simply sat at the end of the corridor to make sure nobody came out of their rooms to people taking others out with what you and I would agree was not sufficient infection prevention control training. Having said that, I don't think policemen or ADF necessarily are automatically skilled up. So everybody who does this work requires training. In my perfect world, the plane from overseas would land on an airstrip that's next to a quarantine station. It wouldn't go through a major city. I think Darwin satisfies that with Howard Springs. You can contact me if I'm wrong, but I understand they're most likely landing at Howard Springs. So you would need a large, dear me, I think there's one in Sale. No, I'm not running the show. Okay. So I want you to think about, you will have people who have left quarantine, they've been positive, they've come to you, their partner may still be in quarantine, still testing positive, still with symptoms, and there will be people in hospital, absolutely. And then the odd person escapes. When I say escaped, the odd case may not be completely, given through some mistake, and bingo, it's arrived in the community. So the way we operate in COVID normal is I just automatically assume that I am in the 2 days before I get symptoms. That's the way I've conducted myself since the 30th of January. And this is how I conduct my life. We can have friends around now, etc. Outside. Outside is how I do it. My grandchildren, outside. And I'm not getting too close and cozy, etc. To people I don't know. I record in my diary if I've gone into somebody's house. So that you can see what I'm doing. I'm setting myself up such that if I get a tap on the shoulder or a call from the contact tracers, we can establish whether I have avoided being a close contact unnecessarily. So there's lots of people I don't need to get that close to. There's lots of outside shopping I can do. And of course, we all wear a mask when we go inside. Inside shops I'm talking about. I avoid shopping centres. I do strip shopping, along the high street rather than going to shopping centres. That's me. Also, people where I live, I'm in Eltham, people are actually keeping their masks on outside as they go from shop to shop. Really, who can be bothered taking it off? So we just keep them on, and then we've finished our shopping, take them off, put them in a little plastic bag, do my hands, ready to drive home or hopefully walk home. So we don't have to wear them outside, you know, when we're walking home or taking exercise. But you're literally going to have 3 groups of people in your practices. Your patients who come every day, those tourists coming from interstate who thinks this is a bit strange, they're wearing masks here, and so you're going to have to educate them. And our 3rd group, the group who are returning. So you know that they're beginning to return before Christmas. Now, even the flights that you've probably already received return travellers, but what I'm saying is there's going to be a lot more coming, and of course they're coming from countries where there's a high prevalence, which means we're going to have more and more and more positives. So I want you to think for a moment about what it would be like to be in quarantine. You've come with your husband, wife, partner and 2 kids. Just picture this. Let's say 2 little kids of 2 and 4. Let's make it interesting. And you've got a partner who can't sit still. And you've come to Melbourne, a Melbourne hotel quarantine, which they've put great infection control, but unfortunately you haven't got a nice little unit that you can make some food in. And you've got 1 person and 2 little kids who can't sit still. So I think anybody would lose their marbles, probably. And you've got jet lag. I give that about 48 hours before I want to scream. So I think it would have been really nice if, and of course we're all so close. So you can see the advantage of Howard Springs up in the Northern Territory. I think they've actually got a unit, you know, each family have got a unit. Then I want you to figure, and they're on the ground floor. Ground floor, fantastic. People can actually go outside, obviously not mixing with others because they're in quarantine, but they can go outside. Not that you might want to be outside up in the Northern Territory right now, it's stinking hot. But then 5 days later, you have your first swab done at, say, 3-4 days. So you're positive. I think you know what's going to happen next. Another 3 or 4 days, somebody else in the family. So what we're finding is that it isn't just 2 weeks quarantine that people are having. Their partner gets it, the children get it. And I mean, even in Melbourne, we've had families here who've been in quarantine 8 weeks. So I want you to see this for what it is. It's a massive mental health issue. And I've got to talk to the psychologist next week, the college, and that's what I want them to turn their mind to. Because a lot of Victorians are saying, I don't know whether I want those people back. We're saying that about the South Australians, which is a bit mean, but I understand where your head is, and I'm a little bit mixed about how come there were 17,000 people a month ago who wanted to come back, or 2 months, and now there's 35. What's going on? Are they all just deciding they don't want to be in England anymore because it's full of COVID? But that's really not my business. So my business is to say, how am I conducting myself? And yes, a number of those people returning are coming back for cancer treatment, lots and lots of things. We can't just say, oh, they want to be back for Christmas. So people are coming back for lots of reasons. Some of them are kids on those visas that have run out. They've got no money. So I think we need some compassion, always need compassion, but also you need to say in your clinic, how safe am I keeping this for my staff, for myself, and for my patients? So right now you've probably got a few grumpy patients who say, why do I have to wait outside? There's no COVID around. Why can't I just sit inside with everybody else? And I want your clinic to look like there's still a pandemic on, because there is. I don't know what part of a global pandemic people don't understand, but it needs to be a proportionate response. We don't need to have people walking around in gowns. So firstly, what happens to you when you wake up in the morning and when you go to work? It shouldn't be just a little checking your temperature, you're okay, how do you feel, you're okay. It's not like that at all. Let's put some hard yards in when you come to work, because you will be thankful that the day that somebody does turn up and we haven't asked the full range of symptoms and turned them away if they're a staff member, got them tested, or got them tested if they're a patient, we need to be diligent. You'll be thanking your lucky stars that you did that. So every morning you wake up, how is my throat? How do I feel? Don't tell me you feel hungover. I know it's December, but I don't want to know about that. Headache. You don't always know that you've got a fever. It's often your partner saying, oh, burning hot last night. Fatigue, all the symptoms, breathlessness, and if you've got any of them, right through to nausea, vomiting. So about 15% of people turn up with that. And I'm sure you've all read the alert from the Chief Health Officer last week. We've got gastro multiplying out of control in childcare centres at present. So I think you know what's happening there. But don't just assume that it's gastro, because we do know, we've got reports of people vomiting their way to hospital, quite frankly, as well as being breathless, and it's COVID. Even down to particular rashes, I think you know that's a neurological involvement there. So what are the questions you're asking of each other when you rock up at work? Make it automatic. Don't say you're okay. Point the thermometer, the contactless thermometer. I tell you, you've got to do a little bit better than that. What if the person's been taking Panadol? That'll lower their temperature, won't show up. That's what people are doing at international borders, you know, to get back home. And of course, they're not showing up as a fever. So the person might say, oh yeah, look, I had a bit of a headache this morning. I took a Panadol. Guess what? You're not coming in because that could be one of the signs. People go, oh, you're joking. There's nothing around here. Well, it's got to start somewhere. There's got to be transmission somewhere. And that's why you're hearing about the sewage systems picking up fragments of the virus. We don't know whether it's active virus or whether it's fragments, but I think you would have heard yesterday it was Corio in Geelong. Sorry about that. Fancy my phone ringing. It never rings. It's a landline, so I'm just going to ignore it. Turn it right down. There we go. Gone. It'll probably go into message as well. Sorry, everybody. That's really bad. It rings about once a month. It's chosen to do that now. So going back to how you conduct yourself, what is it that we all do? Visiting doctors, everybody. They'll look at you like you've got two heads, but that's what we do in our clinic. We go through that little thing every day. People will get sick of it, and then one day there'll be a case. And it shouldn't be a case of, oh, we better start doing the right thing. A case has got to start somewhere. So prepare yourself for that. Record it. I actually don't like people doing their own self-assessment. So adopt a buddy. What's going on in your household? Have you got a 15-year-old who lives in their cave, never comes out, and eventually complains they've had a sore throat for the last 3 days? You need to know what's going on in your household. And if you've got anybody who's got any symptoms, there's only one thing for them to do, and that's to go off and get a test. So they jump in your car and you take them to get a test. Same with if you're checking a colleague at work, they've got some symptoms, go off and get a test. Now, buried in Tanya's figures today, you saw the graphs there of the tests, buried in there, I'm pretty sure that a number of those tests, Tanya, and you can confirm, will be what we call we're doing a screen, surveillance, deep testing, if you like. We're wanting to see in our high-risk professions, that is our meat workers, possibly childcare, definitely aged care, transport workers, warehouse workers. We're actually testing thousands of those every day throughout the state. So if Tanya, you know, she may already know, or she may not know, or she may be able to find out, but embedded in our figures every day, Tanya, about a quarter to a third of our tests are people where we're undergoing surveillance. So what that tells us is we're testing, say, the aged care workers. I don't know whether it's at 25% get tested every week, so that over a month they're all done. So that's not to see, oh, who's positive? Well, of course it is. But it's also to say, how are we tracking? Is there any remnant virus, or has there been any remnant virus starting up? Because that is like an early warning. When we do surveillance, we do it with lots of diseases, where doctors are asked to automatically just swab, you know, every 10th person for a month for something else. It could be Murray Valley encephalitis that we take blood for. So embedded in those figures, because really, initially, we were just asked to present if we had symptoms, weren't we? So we've actually got, within our testing, we've got different groups. We've got people who belong to those high-risk areas because we want to see what's going on there. We've got people turning up for symptoms, and then we've got people who are not symptomatic but close contacts of positives. Okay, if that's not happening, you know, you may not have those people now because we actually don't have known cases in Victoria. But that is what the next possible year looks like. So this can be very confusing to staff because they go, oh, so why doesn't that person have to stay locked up for 2 weeks? And we go, because that's surveillance testing. So when you're working in aged care and the 25% are tested every week, as long as they have no symptoms, they don't have to quarantine and isolate for 2 weeks, okay? So I would always say to the person, oh, what did you have the test for? Oh, because I work in at the meatworks, and that's where people have got to be close together and it's high risk. So we have professions where we cannot make the profession do its work any differently. I think you know what they are. We'll also probably do, the healthcare workers as well. Those who work in hospitals on COVID wards already are being swabbed. So there are different sorts of testing. It's the same test. The PCR test is the gold standard. That's the one that you're going to take, I think, 12 hours now, the results coming back in. Don't go sideways and say, when are they going to bring in the magic quick antigen test? Because if you see the Chief Health Officer's report yesterday online, you'll see that, no, we are not using the rapid antigen test at this point for our purposes. So don't be schmoozed by people knocking on your door wanting to sell you quickie tests. That is not what we're using in Victoria. It's not recognised at this point. So stay with the PCR test, which I think you've seen enough of that thousands of times on the telly, for example. So if you have a test for symptoms, do you have to quarantine for 2 weeks, or if it's negative, okay, return to work? I'm glad that's from Suzanne Simpson. Thank you, Suzanne. Now, Suzanne, I'm going to put this to you. You wake up with a sore throat. You're really good, you know to go straight away. Don't wait and say, oh, see if it gets worse or better. No, so at 9 o'clock, 9:01, you're at the testing station. You receive a text message at 9 o'clock that night. Dear Susan, you are negative. Now, Susan, take a breath. You have got a sore throat. Should you really be just jumping for joy and saying, it's not COVID, I can go to work tomorrow? Sorry, Susan. Have we learnt a lesson the last 8 months? If we have symptoms, we stay away. And I am praying that what we get out of this pandemic is a much better approach to stopping transmission to our colleagues of anything. So, Susan, stay away until you feel better. You've heard that it's not COVID, but when you wake up the next morning, lock the door. Hang on, I'll get onto that question in a minute. So when you wake up and you have that test done, do not go to work the next day if you still have a sore throat. You are symptomatic. So once your symptoms have gone, and sorry, it's Robin. Okay, she's using Suzanne's phone, obviously. So you see what I'm saying, because I'm already hearing people say this, oh, don't worry about my runny nose, it's not COVID. And I'm going, what are you here for? Because, now you transmit another coronavirus or a rhinovirus. Well, who's going to be happy about that? So can't we learn something from the pandemic? Don't turn up to work symptomatic. Even if you're bragging about it's not COVID, don't worry about me. Well, sorry, what are you doing at work with symptoms? Same with gastro. So, Robin, when you're then not symptomatic, not only do you know it's not COVID, which is great, you actually already, because your work will be rubbish while you're not well. Can I say that? If I don't say it, your colleagues will. So don't turn up to work until you're better. Okay, and that's a day or two. So you can see the workforce is really going to change in healthcare, because remember what we were last, January or this January? It's okay, just a sore throat, but I'll struggle on. I'm nearly dying. Or we don't do that anymore. And don't work with anybody who does that. They're putting everybody at risk. I'm not interested in a practice where a sore throat just goes through the whole practice. I wouldn't thank anybody for that. So no heroics, please. So the other question was, I've forgotten now, it was about, okay, so you don't stay the 14 days. In fact, can I just say, even if you're COVID positive, you can actually get another test done later, and if it's negative, it doesn't even have to be the 14 days. But because we had a pandemic and a lot of numbers, we made it automatic. As long as your symptoms have gone. For some people, their symptoms have not gone by day 14, and they just found it hard to clear the virus, and so they can't be let loose. They're usually in hospital at this point. So this 14 days, you really need to think about it. This virus, it's looking for my throat. Everybody is asymptomatic in the illness. Everybody. And about 15% of people just do not go on to get symptoms that they even recognise. About 15%. So don't believe too much of the rubbish that you've probably been reading. But everybody will be asymptomatic when they're developing just before they develop the symptoms. So we know that 24 hours before the symptoms develop, you're absolutely infectious, and possibly out to 36 hours. The contact tracing is usually done back 2 or 3 days. But what people have been reporting is, oh, no, I had a bit of a sore throat yesterday, but today's day one because I actually feel crook. Well, no, yesterday was day one. So people have decided where their 48 hours back is, and they start calling their friends. But in fact, the day that your symptoms start, and it can be 3 o'clock in the morning, it can be 8 o'clock at night. And of course, if your symptoms come on any time during the day, you leave work and you go and get a test. So do know what's going on in your household, because this sort of stuff, that responsibility that we have to ourselves and to our community is huge, but it costs nothing. And that's what we ought to be doing. You'll get sick of it, but if I'm still here in a year's time telling you to do it, it obviously means that the vaccine hasn't arrived. And I want to talk about the vaccine in a minute. So I'm not sure whether we can get that other question up. Tanya, can you read it out for me?
I can read it out to you. Are you suggesting GP clinics in regional Victoria should continue to lock the door and only do telehealth for 2021? Doesn't this suggest that COVID safe plans, contact tracing and practice procedures are inadequate to protect the practice?
No, I'm not suggesting that at all. So I'm talking COVID normal. So that's an awareness that it hasn't disappeared, but neither are we at the height of a wave. So what I imagine is that a practice says, I actually need to just check. Anybody who walks into this clinic, needs to get past me, Nurse Ratchet, the practice manager, whoever. And so that's about saying I'm very aware that people coming into my clinic have not just got a mask on, but there is an awareness of symptoms. Definitely keep your spacing. If it's a nasty day, you might decide to have people inside. So it's not about locking the door. Remember, people need to look, see and feel that this place looks a little bit different to the way it looked last year. And how this is that they don't necessarily just book online, or if they book online, you're going to see them again. They don't just walk in, plonk down, take a seat. That you have a strategy, and the strategy can be not necessarily lock the door, but you've already told them when they've booked there to maybe wait outside, give you a call. Telehealth, you can mix it. Some patients you'll want to keep telehealth, others you'll do a little bit of telehealth. This is in the same space, and then you'll say, I need you to come in, and you might conduct the rest of it inside. But instead of having a 20 or 30 minute face-to-face where you could have done 10 minutes or 15 minutes off-site on telehealth and 15 minutes, closer up, you choose to do the less close-up face-to-face. That's the way you operate in that space. You say, I could be positive. What am I doing to protect people without being ridiculous? So you say, well, we wear masks. Isn't that good enough? I've got a mask on. Why should the patient wear a mask? Because you wearing a mask is about 40% protective. Both of you wearing a mask is about 80, but there's no such thing as 100%. You can improve that, reduce that risk by moving back from the patient when you've examined them, by spending less time with the patient, by having your windows open, by doing, chatting to the patient if you want confidentiality, walking them back to the car park. Lots of doctors have told me they love doing that because they get outside. Some of the doctors have actually just chosen to do examinations in their treatment room. They put curtains up and they're using their own consulting room for telehealth and making a cup of tea and stuff like that, where they don't need to wear a mask and they feel a lot more relaxed. So people have chosen all sorts of different ways. But I think the day you think, next week, the day you think it's not around, I'm okay. Well, what is it that you're doing? What is it that tells me as your patient, oh, they've taken all the hand rub away? Well, don't do that. Do your hands when you come in. Have you got a mask on? If you haven't got a mask on, knock on the door. Somebody will bring you one. But the day you say it's gone is the day you've just set yourself up for a huge fall. And I can tell you that the people who test positive each day, even the arrivals, very few of them would have expected that test to be positive, because as human beings, we actually assess our risk as low. And you've had positives in Gippsland, and you've had to fight some people, and they've turned out to be positive. When I say fight, you've had to take them on and say, no, you're symptomatic. I don't know, I wouldn't have COVID, and they have. So we're only a plane and maybe a truck driver away, and all of us are linked with high risk occupations. There's absolutely no doubt about that. But this is not about being frightened. This is just about how do we conduct ourselves. So one of the things that has failed us during the pandemic is healthcare staff saying, I'm okay, it's those filthy patients out there. And so we've got records of staff going to the tea room and taking their mask off and putting it on the tea room table. Whoa. So this is not the sort of stuff we do. How much do you want to use the tea room? Well, I can tell you that if I ever come to see, well, I won't be visiting, but I would be offered a cup of tea outside under your market umbrella or your marquee or your tent or your bit of shade cloth, and that's much safer. Okay, much safer. So have your, cups of tea outside where you don't need to wear masks anyway. I know you don't need to wear masks when you're eating, but just look at how you can actually make life safer for you. Charlene has just said, and Shirley, looking at going disposable linen. Shirley, I think this is a great chance to say, number one, do I even need a covering on that couch? Because I'm not keen to replace linen with disposable linen without thinking first, do I actually need to have anything there? And I hope that the answer is no. Best practice in the treatment room is nothing, of course. If you have a disposable sheet, you might just choose to change that a couple of times a day. But really, why are we even using them? If there's something wrong with your couch and it's got big rips in it, you can't even clean that effectively, so you get it recovered. So here's a chance to say, do we actually even need pillows? We've all got adjustable headrests on our couches. Why have we even got a pillow? I go into so many practices where the pillow's in a cupboard, just taking up space, or worse, on the floor beside the clinical waste bin. Here's a chance. So yes, you can tear off little strips of Versatile, pop them over a chair, and just say to the doctor, look, when you're expecting, if it's a really cold day or, skin contact with the couch, if you want to put something, here they are. I wouldn't really give a roll to a doctor. I mean, you can imagine how much waste there might be, or it never gets used for 3 years, thinking about my doctor. But certainly give them a little pack of, Clinell or Toughies or something like that, and just say, look, here's your wipes. Patient really appreciates, I tell you, I'd rather have a damp, clean couch than something that I don't know how many people have lain on. And obviously use something like a bluey, or there's other stuff you can put down that comes off a roll that you can cut for waterproof as well. It's cheap when you cut it yourself. So yes, I would look at reducing waste, reducing linen. Great chance to get rid of stuff that we don't need. But also respecting that some of the doctors and nurses do like linen, perhaps give them the bill, all right? And the bill always goes up. It never goes down with linen. So don't just replace linen with disposable. Have a think about, how does my practice look? Even the paper towel will absorb, will absorb odour. Somebody says, can we go back to Clinell white tubs now and stop having to use the green? Look, I would probably stay with the green probably now into the foreseeable future. But remember the green, which has got, I think, 4 disinfectants in, and that's one of them is actually a detergent as well. I would actually say that's my cleaning step. And then when I actually do need to disinfect, I use another one, and it's got to stay wet. Okay, so use one to clean. That's your cleaning step. So it's always 2 steps. Or you can use your yellow one to clean, and you go over your high touch surfaces. You do that at lunchtime and again at night time, your high touch surfaces. We're still doing that. You go over the buttons, rails, handles, etc. with the second wipe. So ordinary cleaning you can do with your white, or I'm just going to show you what the person means. Toughies, I think Toughies 5 is automatically a disinfectant, but the Clinell or Gamma Healthcare have got the detergent, and they've got the, they call it universal. So yes, it does have 3 or 4 chemicals in it, but as long as the green one stays wet, for a couple of minutes, you'll get about a 4 log reduction in virus. So rather than just say, oh, it's not around and I'll use that stuff when I need to, how good you're cleaning. How good is the cleaning? How diligently is it being done? I would still definitely be using a disinfectant wipe on my high touch surfaces, absolutely. So just giving you a bit of a flavour, an overview, big picture about what this is like. So yes, people are still having that one little step. What you decided is yours. Your little sign on the outdoor might be, give us a call when you've arrived. A lot of people do that on their message automatically. Give us a call when you've arrived, remain outside until we call you in. I think that's the best one. The doctors like to have the next patient waiting. So again, that's just a bit of organisation there rather than calling in a patient having downtime. Some of the doctors don't mind the gap because they do some notes and bits and pieces. Everybody's different, but just say what works in my place. I can't really have a full waiting room. And you know what? I don't want a full waiting room. Some people put a cross on the in-between chairs, but really people in their car listening to their music, and just give them a call to come in, or just say to them, come in 10 minutes. I don't think that's reasonable. There was one more, magazines and toys. Can we kind of like see them off, please? Please, them and linen. If I was running the show, there would be no shared toys, no magazines. So here's a chance to just give magazines away, give toys away, and we're not interested in sharing. I don't think too many parents would be demanding a toy these days. So you see that we're not going back to normal. We're going to COVID normal. Okay, you might say, oh, but Mark, the risk is low. Well, as I said, that's what those 8 people who tested positive yesterday said the day before. The risk is low. Of course, it's lower here. But what I'm saying is you're about to get a flush of people who have been positive back into our community, and the risk is that those who cared for them while they were infectious, there's a risk of a breach, and breaches happen. We try not for them to happen, but you can see what we're up against in Australia. So patients do their hands, they've got their mask on, they wait a minimum time. Sometimes they're seeing part of their visit by the doctor online, telehealth, and the other half in the clinic. Sometimes the doctor goes out to the car and conducts the whole thing outside. Some places have set up a bit of a tent where the patient, if it's a nice day, can actually go into a marquee and be seen there. It all depends. But keep your sneeze shields up, keep your alcohol hand rub there. Patients have theirs, you have yours. And also the Medicare machine, everything should be contactless. Can we just say we're not going backwards? I've seen lots of practices that we've definitely improved. Definitely. Let's not go backwards. Keep the sneeze shield, and the patient can tap, their Medicare thing. Any paper that's got to be transferred, pop it into a plastic pocket. Don't assume that you're negative. Okay. Just think about the contact tracing. So the contact tracing in Melbourne is probably now better than anywhere else in Australia, because what they've done here, I'm sure you're aware of the issue with the public health unit. It was centralised in Melbourne, whereas in the other states, and it had the guts ripped out of it, quite frankly, I'll be political, in the 90s, and not rebuilt by successive governments, so we can blame everybody. So we've now followed the model where in all of the regions we've got local public health units that are skilled up, trained up, ready to go. That's why we should not see what happened in July and August. And can I actually say that what did happen in July and August, if you're not aware, was that embedded in the end of the first wave, embedded in its tail, was the start of the second wave. We couldn't work that out because it was the same group of people. Okay, so you don't know that that's happening. It was only when they did the genomics and they said, hang on, we've still got some remainders of the first stuff that came in March, that type of COVID, SARS-CoV-2, but we've got this new one. So security workers. So they were the same group. It was in the same suburbs. You would have remembered how they were sectioning off suburbs because we couldn't work until you do the genomics, and that takes a good week or so. What's going on here? Oh, we've got a new strain that's popped up. In terms of the virus itself, there has been a bit of an increase in transmissibility since we first got it in in late January, early February, but it hasn't like mutated wildly. You know, people sort of shouldn't get carried away with that. So how do we attract our patients back? Do you have patients who don't want to come back? And I know that there's a real issue in the hospitals at present because people are presenting quite late with heart attacks and strokes, whereas if they'd gone to see their doctor, their regular check. So I would hope that an amount of your time is spent chasing patients and saying, you know what, you missed out on that diabetes check. So here's a chance. December's going to be really busy. Here's a chance to get people sorted out before Christmas, review medications, etc., etc. But a lot of us, you know, put off pap smears, mammograms, all that sort of stuff, because I don't want to go there. I might get something. And so there's a lot of follow-up work to do. But we want the patients to be welcomed back in a COVID-safe way. And I've described what that is. They need to be confident that you're taking all precautions. They shouldn't be seeing drink bottles on the front desk. You know, that virus is only looking for your throat and you've got a drink bottle beside you because, oh, well, you know, I'm a bit dehydrated. Well, why aren't you having a break every 2 hours? I'm a little bit strict about this. So your mask, you can forget it being effective after about 2 hours, and you must wear a surgical mask, not one that you've made. So why not use that 2 hours to go to the loo, become hydrated, change my mask? And for the managers who are watching, to keep in mind, and I might have to stagger that. It doesn't have to be a long break, even 5 minutes, but you can then see you need 4 masks per day at least. I don't mind if it's 2¼ hours or 2½, but if you have a look at the way the mask is made, and I did have one that I was showing a group the other day where I cut the mask and I opened it up to show you the 3 different, here it is, the 3 different layers. So this middle layer, there's the layer that goes outside, that's the green layer. That's slightly waterproof if you like, and the inner one is just more comfortable against, but all of them do have a protective role. So this 3rd layer, or the middle layer, it feels like skin actually, but you can put a drop of water on that and it'll sit nicely as a bubble for a short time. So this is your cough people's droplets coming through, and then eventually it soaks in. So these have a limited life and it's about 2 hours. So I know you might have read about heroics of people 4 hours. Well, I would say that it's pretty useless after 2, but isn't this a good chance to hydrate? So nobody should be drinking at their desks with masks inside, ever. And of course, as soon as you've taken your mask off, it's hands, you're making your cup of tea, going outside. So these are some of the ways that we conduct ourselves. In terms of removing the mask, there's only one place for a mask that's removed, and that's the bin. Nowhere else, not in a pocket, nothing. So when you're so you know that you're wearing your mask properly. It's about halfway down and it sits there so it doesn't fog up. So to take your mask off, it's both hands away and down. And it's into the bin. So you may end up having a bin in the tea room for the used masks, some alcohol, and then somebody makes their cup of tea and goes outside with it. I'm really not keen on people sharing, large groups in the tea room. There was a case when the big outbreak was on, I think at St Basil's, or it might not have been St Basil's, it might have been another aged care. They actually chose to have a baby shower in the tea room. And of course, that was a super spreading event. So super spreading is where one person is close to a lot of others, and bingo, it's off. It's not one person, then another person sheds it to another person. It's all at once. So restaurants, bars, famous for that kind of thing. Now, what I was going to do is just talk a little bit about the vaccine. So you're now thinking, how alert are we? She's brought us back into the real world. Yes, we're not in our little nirvana here really, and we're about to get a bit of a shock. That's what I'm saying. Then you go, oh, we've got the vaccine coming. Well, we've got about 3 vaccines that we've, bought into, if you like, or looking at that look okay. But really, I mean, the phase 3 trials are coming in. We know that the safety is there. There's been a little bit of murmur about the Oxford AstraZeneca one, because by mistake, they gave a number of people half dose and then gave the full dose a month later, and bingo, they got an amazing result, 90%. So who knows, maybe that'll actually be the way it's given. So what it looks like is that it will be rolled out for healthcare staff and the vulnerable. Now, when you say who are the vulnerable, I was interested to read about 1/3 of our population we treat as vulnerable. I can't believe it. Phone's ringing again. Sorry about that. So we've got 3 vaccines and, you know, we put deposits on them. Our winter is not coming up till next, May. In my dreams, we get the flu vaccine and our first COVID next April. That's my dream. And then a month later, you get your second COVID. So it looks like it'll be 2 vaccines, okay, or 2 shots, 2 doses, about a month apart. A month allows you to get some stimulation going of the immune response. What I can tell you is the immune response, we're not sure whether it's predominantly antibody, which is B cell mediated immunity, or T cells. It's probably a combination of both. You might say, well, what's B and T cells? So B cell is antibody production. T cell is where we stimulate cells to recognise, the cell that's infected and get rid of the virus, etc. So generally we have both responses occurring, but some dominate with some infections. So we can't really measure adequate, off the cuff T cell response, but we can measure antibodies, and I'm sure everybody knows that, but that's a sign that I've got some protection. Antibodies wane, but it's really the memory cells that you produce that kick into things. So what we don't know is how long the vaccine will last. So my hunch, I would love, is that we get our 2 shots when we go for the flu shot in April or May next year. So it's going to be dependent on a number of things. If we get a massive wave coming in early next year, when a lot of the people coming back from overseas, higher proportion are infected, I don't know what's going to happen, whether they'll scale up the production. But my hunch is they're going to be spending most of their vaccine doses in the Northern Hemisphere over this winter. That's my hunch. What would be the role of general practice? Well, I'm sure you've heard one of the vaccines has got to be kept, I think it's minus 20. Now, don't freak. I know you've all got this idea of an esky, but there are some pretty amazing type of eskies around, and they can keep it at minus 20 for a couple of weeks with a couple of refills. So I don't know whether it's going to be general practice that delivers, or whether some of the respiratory clinics also scale up and do some of that themselves, or how staggered it's going to be. Now, can I say that the only way we know that the vaccine is actually working is by still doing all of our testing. We can't stop testing. Testing is our way out here. It's our way to, COVID normal. And I'm pretty sure everybody appreciates COVID normal right now. With the vaccines, there are different types. You've probably heard of the messenger RNA vaccine. This is the one that's got to be kept. I think this is the Pfizer one. This is the one that's got to be kept at minus 20. And so what this does is this, it sends a message in the cell and makes it produce spike protein, and then the body produces an immune response to knock out the spike protein. And so we know that those antibodies will attack any spike protein from any COVID virus that you're infected with. The other is a simple adenovirus that they've inserted some of the RNA from the virus into, and the body just produces a response to that immediately. All of a sudden, people want to call me. Sorry, everybody. Now, what I might do is, given that we should have a few minutes for more questions, so you can see we're in a space that we've never been in before, with a vaccine that we've never had before, that we don't know, in fact, how good it is. What we really want is a vaccine that works really well in preventing transmission or preventing serious infection in the vulnerable. That's what we really want. So we'll see how we go. Now, any other questions come up, Tanya?
Not at the moment, Marg, but I do just a clarification. The respiratory clinics only tested symptomatic patients. So, and the other data was unidentified, like de-identified before we got it. So I couldn't do or how or where they worked. Yeah, so that should be identified when it comes through Polar.
Right. You can usually work out, like, I think there might, let's say there were, I don't know how many thousands of tests there were today, but, or, you know, reported today for yesterday, but let's say there were 7,000 tests reported yesterday. You can bet your bottom dollar that there weren't 7,000 or 6,000 symptomatic people tested.
Yep.
No way. Because we know that the level of colds is quite low. Although, can I say, with childcare reopening, guess what? The snotty noses are back, and certainly the gastro's there in you know, big numbers. That's telling us something about infection control, isn't it? But you can bet your bottom dollar that about 3,000 swabs are being done every day in Victoria as part of surveillance. So, which is really, really vital. So don't sort of think, gee, today they had 12,000 tests done. God, are there a lot of sick people around or something? And the answer is no. A lot of that is the surveillance testing. So thanks for that tip about the respiratory clinics. But it wouldn't surprise me if we did more testing, devolved two groups that are really skilled at doing it.
Yeah.
Wouldn't surprise me, because I think the GPs are going to be absolutely flat out with all their normal patients coming back in and getting worked up for their programs that they're on, whether it's diabetes, wounds, etc. And I hate to say it, but you are going to see patients who are absolutely worse for wear for not having seen a doctor for the last 6 months. Is there somebody asked, is there a recent update to the industry restart guidelines for primary health service? I can't see the rest of it.
Is there a recent update to the industry restart guidelines for primary health services that we can reference for going forward in COVID normal?
There is, just for ordinary workplaces. Look, I had a look at some of the WorkSafe stuff and I go, ooh, I think general practice is going to have to accept that it has people with symptoms coming, whereas almost every other workplace doesn't. It can shoo them away. Even the dentist can shoo them away. So I would hope that there is a specific, you know, RAC GP thing, but it may even differ from state to state. I don't know. But to be able to say to yourself, these are the things that I do. These are the things I do. I can't stand this, another call. These are the things we do at our practice to keep our staff safe, our patients safe, and should there be a case, we can say these are the things we do. Because what you want to achieve in the end is to be able to say there was no close contact, except for maybe the doctor, but then the doctor chose to do less than 15 minutes face-to-face. The window is open. Do you see how you want to put yourself in the space of the lowest risk possible? Because sure as eggs are eggs, there'll be that phone call. And it's already happened to me with a couple of my practice clients, not even in Melbourne, actually in country Victoria. And they were actually designated close contacts. They just weren't doing it correctly. The patient sat in the waiting room, you know, eventually went off and had a test, was positive. Clinic had to close. There we go. What do you want? Do you want to be doing really diligent stuff, questioning each other, having it set up as COVID normal, or do you want that phone call that says you've got to close and have a deep clean and you've got to close for a couple of days, and by the way, your staff have all got to be tested, they're close contacts. That's what we're looking at. I know what I want to put my practices in the position of doing. Do I think the latest guidelines for clinicians not to need to wear eye protection? Tier 1, I don't even ask you about all the tiers. So if I'm in a room on my own, and we are at pretty low risk in Victoria right now, the eye protection is probably not making much of a difference. Okay, so you look at the risk. So you say, you know what, but I'll tell you what will make a difference, me standing back when I don't need to be close. So this should start to become automatic. I may not wear eye protection. The patient has no symptoms. And of course, if I'm seeing them outside, probably wouldn't even wear a mask. But these are the way to look at your risks. The best thing you can do is to be outside. If you've got to be inside, door open. Now we're coming into hot weather, and I've got some bad news for you, because air conditioning, and probably fans too, unless it's, and a lot of these are unrecycled, but even if it's fresh air, is it being purged? Where's it going? It's blowing all over your face, from the patient's face to yours. That's where it's going. And so what people might do, and I was speaking to one up in the mountains, And they said, oh, look, a couple of us are really early people here. We're actually going to open our clinic at 7:30 in the morning. A lot of our patients are already at the door at 8. So we're going to open at 7:30 in the morning. We're going to close for the heat of the day. We're not even going to use our aircon. And we're going to run some evening sessions, you know, starting at sort of 5 and going through till 9. People are doing all sorts of things. So the pandemic plan asks you to look at alternative methods of delivery, but even running your clinic. Now, I'm not saying you can't use your air conditioner, but I'm saying look at where the risks are. And we know that we had these massive spreading events in restaurants. It just took one person sitting under the aircon, talking to the others, and it blew to 3 tables. They had 12 people positive, who then went to church and infected, you know, another couple of hundred. That is how it happens. So you go to lunch at somebody's house, you sit outside, I won't be doing evening meals. It just reduces risk. So this type of health, public health, is so different to what I call medical health one-on-one. It's really hard for a lot of clinics to get their heads into that space, that this is a community thing, and what am I doing to reduce the risk? Oh, I have somebody over for lunch and we'll have it outside. Instead of a cup of coffee in my house, outside. So look at all those risk reduction strategies. Now, it's not a case of, oh, I'm just going to run my clinic as normal and I'll pop a mask on. That is not COVID normal, because you're ignoring the symptoms for staff, etc., and you're ignoring the capacity to open windows, etc. Somebody says they haven't been vacuuming in high-risk consulting rooms. Now, you can vacuum clean, but have the windows open. Make it the last thing you do. It wouldn't be my big problem. Can I say with cleaning that there's very little evidence that this virus is being spread? I've got to be careful if I say through the environment. I mean through surfaces. But this is what we have found out, that where you've got your gloves on and you've been feeling a patient's neck or throat or whatever, and you've got, you know, what on your hands, and you touch a surface and then somebody else touches that surface back to their mouth, that's where the risk is. So with the vacuum cleaner, it wouldn't be highest on my list of things to change, but I might say, do you know what? We've been vacuuming like maniacs 5 days a week, and you know what? We haven't been vacuuming recently, and we think we only really need to vacuum twice a week. Well, guess what? There's a good change. So it can be a risk reduction strategy, but you've actually found out something about yourself. And it's a bit like even lockdown. Some of us have found out we don't need to be in the car as much as we were. Some of us are getting more exercise. So it'd be good if we can take the things we've learnt, especially about infection prevention control. No food where you're working. No food where you're working. That virus is just looking for receptor sites in your throat, and it will find them. Not so much the eyes, but there are receptor sites on the conjunctiva. So you can see that's why we've removed for that, I think you said tier 1. I've got to say, my eyes glaze over when I start to read. I know tier 0, I think we've eliminated, but we'll probably go back to it because that represents our situation in some areas. I think tier 3 is where you're full on with a number of people in a closed space. So one of the things we have learned with this pandemic is we've really got to be careful about the way we use the words airborne, aerosol, droplet. So I can tell you that when you cough, big droplets, little droplets, and some of those little droplets split, they dry off, split apart, and they suspend. This has been the issue that has come to our attention. And if you've got 4 COVID people in your ward and you're there for hours at a time, we now learned that the surgical masks are not sufficient. So it doesn't really apply to general practice, but they then gave them the P2 N95 masks, but that was that situation. Also aged care, where I had people, you know, 3 or 4 people in 3 rooms adjacent to each other. They gave them the P2 N95. Now, the sad thing was that about 80% of our national stockpile, probably, I don't know, was it bought on the cheap or bought by somebody who didn't understand, fail the fit test. The first test we do is a fit check. We always do a fit check, and that makes sure that we've got a seal. But the fit test is a different beast altogether, and it's done once this passes the fit check. They put a thing over your head and put some gas in, and if you can taste the gas, or they measure something, actually, to make it more accurate, they measure something and they say, sorry, this is not forming a good seal. One of the things I noticed with the P2s, and again, you guys shouldn't be using them, is that I actually saw some P2s that had ear loops. Now, I think you don't have to be Einstein, but if you've got ear loops and you move your face, you break the seal straight away. So you can see this is why the staff in hospitals were really up in arms, because here we had this gold standard test, but these around the world. So you'll see on a lot of television now, the report, they'll actually have the PA/PR, with the tube down the back for when they're working in the COVID wards. But we certainly don't need that because we're not hanging around in rooms where people are staying for a long time. Our patients didn't have masks on in those hospitals. So they were really pumping out lots of virus. Okay, that's enough of me. I think you guys are ready to go back to work.
Now, is there any last questions from anyone if they'd like to take themselves off mute? No? I think that just about concludes it. Thank you so much, Marg. You're always a wealth of information. Thank you everybody for tuning in. And as I'd just like to reinforce, if you can do your evaluation, we'll send out a certificate of attendance.
Right. And apologies for all those phone calls. I just can't believe it. I tried to turn it down.
This is what happens with our Zoom meetings. I think everyone has something a little bit different when we've done them from home. So whether it's a cat walking across the keyboard or whatever happens.
Thanks, Michael. Happen. Michael's still awake. That's great. Thank you,
everyone, and we look forward to seeing you soon.
Good. And certainly debate that stuff with everybody you work with.
Yeah.
Okay. See you later.
Thanks, Marg.
Okay, bye.
Thank you, everybody.